Thank you, everybody, for joining us tonight. Again, this is another heart-trending webinar coming to you on the third Thursday of every month at 5 Central, 6 Eastern Time. My name is Chadi Alraies. I'm director of the Cath Lab at Detroit Medical Center. This series comes to you with experts in different fields in the cardiology, interventional imaging, as well as endovascular therapies and structural heart intervention. We highlight that the purpose of this series is to highlight techniques as well as feature some new studies as well as case discussions. And this is just to reiterate and also keep the hand on the pulse and what's new and kind of upcoming in the interventional space. I'm really today privileged to be with Dr. Sameh Sayfo, who's a dear friend and a phenomenal operator. Dr. Sayfo, and interventional cardiologist and endovascular specialist at Plano Scott & White Heart Hospital. He finished his training at University of Damascus and an MBA in finance from the University of Texas, Dallas. He did internal medicine training in Indiana University and cardiology fellowship at Louisville and interventional cardiology fellowship in Brown University. Board certified both ABVM as well as RPVI, internal medicine, cardiology, interventional cardiology, and he is the director of PERT program at his current hospital, as well as the director of endovascular fellowship program, which is a 1-year extra fellowship beyond interventional cardiology at Baylor Scott & White Heart Hospital, Plano. Dr. Sayfo, thank you so much for being with us.
Thank you for having me. Very excited to be with you guys today.
Thank you. So this is going to be very interesting. Just talk about new techniques in critical limb ischemia. This is a field kind of evolved over time in the interventional space. Covered by interventional radiology as well as vascular surgery, but definitely the field has evolved a lot in our space. So I can't wait to hear your presentation.
Absolutely. I'm going to try to kind of highlight a couple of points throughout the presentation, and I'll make it interactive. Please stop me, and if there's a way for the audience to ask a question, they just send us a chat or interrupt me. The critical limb ischemia, it's really one of the most prevalent disease we have, but we ignore it a lot. I think the reason behind it is lack of education behind it and not understanding how dangerous this disease is. I always make a joke for the cardiology fellows that when they graduate on their paper, on their graduation certificate, they have cardiovascular disease. That's 50% of their fellowship is vascular. And unfortunately, still not just cardiology, but even other subspecialty, critical limb ischemia is not being managed the way we think we should manage it in a first world country. And I'll show you some data to show that. We'll go back, just give a highlight of the prevalence of the disease, and then just go from there. And then we'll talk about there's a lot of technology coming up, so. I think this is a very common, very popular and well-known slide that's presented in many conferences, just looking at the overlap between coronary artery disease, PAD, and cerebrovascular disease. And a lot of our patients, especially in the cardiology field, when they come to our clinic, we're really good at diagnosing and treating patients with coronary artery disease, but we forget that those patients overlap with cerebrovascular disease from carotid stenosis to PAD. And PAD, of course, claudication is one, but critical limb ischemia is the other way that the patient can present themselves. And the vascular disease risk factors are very similar to coronary artery disease. The high blood pressure, the smoking, the cholesterol, the family history, and activity is also important. With diabetes, we'll see with all the new agents, if controlling diabetes at the earlier age, are we going to have better PAD management? But unfortunately, smoking, not only in the US, but across the world, it's a real pandemic. And intermittent claudication is a common symptoms, and I'm going to go over the Rutherford classification because it's extremely important to recognize where your patients stand in what category, because it's important. It's different prognosis and different treatment, and the urgency for treatment is different. So intermittent claudication, this leg weakness, fatigue, discomfort, but it's not pain per se. I mean, this is, I think, very common mistake when we ask our patient. Very similar in coronary artery disease. When we ask our patient, do you have chest pain? They think stabbing pain, but angina is not a stabbing pain. Same thing with claudication. Pain is more achiness in the calf, inability to walk. When you get the patient to critical limb ischemia, that's where it becomes very dangerous, when they have resting pain or they have developed some ulcers or tissue loss. And if you notice, first presentation of PAD can be CLI. 50% of patients who received below-the-knee amputation were asymptomatic 6 months prior to surgery. So the question is, are they truly asymptomatic, or are we as physicians not asking the right question? PAD is very common, affecting a lot of patients, 8 to 12 million patients in the US, 150,000 amputation, up to 2 million have CLI. It is very, very prevalent disease that we see in our patient population. And that really, regardless where you are, if you are in a big city, metroplex, or even in the rural area. If you look at Rutherford classification, asymptomatic is zero. Go ahead.
Can you just pause for a second? If you go to the previous slide, I just want to highlight, we have primary care hospitalists, resident, and fellows on the webinar. It's just there's always confusion about claudication or the claudicant and between the critical limb ischemia. So, and I know you're going to go over the Rutherford classification, but can you kind of elaborate more about the difference, the main difference between these two categories, and how to look for them with these patients?
Yeah, so the claudication, as we mentioned, is the patient who has reproducible leg discomfort with exertion. Means patient says, I walk a mile. At a mile, I start having achiness in the calf, achiness in the buttock. I stop for a couple of minutes, it goes away. I go walk for another mile, it happens again. This is very typical. Again, it's not pain. I think there's a very common wrong question to ask the patient. And unfortunately, across the subspecialty, from medicine to primary care physician to cardiology, even to vascular specialists, we ask the wrong question. We ask for pain. It's not pain, it's achiness. And sometimes patient tells you they're not able to be active. They cannot exercise because their leg bothered them. They get fatigue. Critical limb ischemia is different. That's when you get the pain to a resting pain, when the patients can't even sit still because their leg hurts. That's when you have a really poor circulation all the way to the toes and having this ischemic pain all the time. When you develop an ulceration, that's a different category of critical limb ischemia. Ulceration can be just, like this case, for example, is the bottom of the foot. Most commonly for diabetic patient, they have neuropathy. They don't feel the ulcer happening. It's very common for primary care physician, for internal medicine physician, family doctors to encourage their patient with diabetic when they shower to dry their feet and look at it every single day. If you catch it early, it's much simpler to treat. Different type of critical limb ischemia, when you get to the gangrenous part, that's a big problem. And I'll show you, let's jump to this one because I think this also helps. Rutherford classification is another way to look at it. From 0 is asymptomatic, basically patient active, if he's doing well, has no symptoms, you just treat conservatively. When the patient has symptoms, that's when you have mild claudication, moderate claudication, or severe claudication, and that depends on how far can they walk. That's we can put them into category from 1 to 3. Resting pain, that's when the patient said, I have pain all the time, even without walking. That's when you get to the category of a critical limb ischemia. You have some minor tissue loss, you become Rutherford 5, and 6 when we talk about gangrene. Unfortunately, because one patient don't know what to look for, and our patients, when they come to all specialties, they are coming wearing shoes. So it was when I started 10 years ago, one of the things I requested in the clinic is like, all of my patients come in, they need to take their shoes off. And I think, early on, the patient understand why that is, and then eventually you teach them why that is, become a more acceptable practice. And I really recommend people to do that because you can see venous ulcer, you can see a wound, an infection. There's a lot of things that you can see in patients, especially diabetic patients. I hope that kind of clarify it. Just I tried to simplify it as much as possible.
Sure, yeah, perfect. Yeah, one question came: is calf cramping or spasm is considered intermittent claudication?
With exertion, can be. Again, you got to be careful. Sometimes patient can have what's called Charlie horses because they're dehydrated, their potassium is low, they're on diuretic. That's different. When patient tells you, I wake up in the middle of the night with cramps, that's not claudication. That's not even arterial disease. That might be venous disease, maybe dehydration, maybe low potassium. But the symptom can range, like angina. The symptom can range from typical angina discomfort to atypical to shortness of breath. Think about it this way. In the leg, it can be cramps. Patient can say, I walk 2 blocks and my leg cramps, I rest, goes away, I walk another 2 blocks, it happened again. Reproducible discomfort is the key to recognize it. When we talk about critical limb ischemia, from an interventional perspective, in the old days, we used to think just get an inflow, means you get the iliac artery, the SFA open, that's sufficient. Unfortunately, well, we learned really early on, and now in the last few years, that that's not sufficient. You have to have a flow to where the wound is. If you have a wound, you have to have the blood going to the wound. And this is to show anatomy between on the left side at a normal below the knee angiogram when you have 3 nice vessels with a nice arch, no disease, versus the one on the right side where the patient basically have all this blood coming through collaterals. And we're going to talk about many different technologies that we have available to open this one up. But if you want to look at claudication versus critical limb ischemia from a different perspective, look at it as prognosis. I think that's important. When you look at a claudication patient, they may have a stable claudication almost 80% of the time. 5 to 10% they can develop critical limb ischemia. Some they get worsening claudication. But if you look at critical limb ischemia, that's in 5 years outcome. But if you look at a critical limb ischemia patient, so the patient went from claudicant to resting pain, from claudicant to an ulcer, it's a different ballgame. Those patients are much sicker. We're talking about amputation. We're talking about mortality. 25% they die within 1 year. So it's extremely important. Now I learned something from our friends in the Say Alive Global Society that it's important to talk to your patient with a critical limb ischemia the way we talk to our patient with cancer. This is a long life relationship. This is cancer-like disease, and we have to treat it the way in that manner. Unfortunately, even when we look at this, there's a lot of awareness among vascular specialists, but this is maybe a year old, 10 years old. But if you look at Medicare data, 54% of patients who had an amputation had no vascular intervention. 17 had an intervention, 17 had an angiogram only, saying nothing can be done. We see that all the time. We see patients second opinion, third opinion, and say nothing can be done because nobody tried to do something. And I'll show you some technology, and I hope that spread the word to a lot of our colleagues who are in the wound care, who are in the podiatrist, the primary care physician, to know that there is something, and sometimes getting a second opinion might be important in this patient population. Talking about medication, even with just simple medical therapy, what we say optimal medical therapy, in heart failure, there is an optimal medical therapy for heart failure. There's optimal medical therapy for PAD. Antiplatelet, only 38% of the patients, statin, 35%, exercise and diets, only 20%, even though the class 1 indication, and smoking cessation is only 36%. And I'm not talking about successful smoking cessation. It's counseling, just talking to them, say, hey, you may want to just quit smoking. This is just a summary of what considered an optimal medical therapy based on the PAD guidelines 2024. And I'm going to go the route of the intervention in this talk, but I really recommend people, operators, physicians, primary care physician, PAs, podiatrists, to really be the defense for line for these patients. You'll be surprised when sometimes you see patients been seen with multiple physicians, but they're not on statin, they're not on ACE inhibitor, they're not on rivaroxaban. I'm going to pause here before I move to the interventional part.
No problem. For Riva, you mean rivaroxaban, right?
Correct.
Xarelto.
Yeah. So the Voyage trial and the Compass trial has shown one for basically a patient who has PAD without an intervention, one with PAD with an intervention, and both has shown a significant positive outcome. Of course, you want to try to do them with minimal anticoagulation. Means if you're on aspirin and Plavix, I'll replace the aspirin with a Xarelto instead of having them on triple therapy. So I think that's extremely important because there's an increased risk of bleeding.
Perfect. And
When
what
we
is
talk
the
about
what is the ACE inhibitor, Sameh? What's specific
so
about
the
ACE
ACE,
inhibitor?
so ACE inhibitor was not specific medication, but the study that showed a patient with hypertension and PAD with ACE inhibitor, there's a better outcome if you start ACE inhibitor. There's no specific ACE inhibitor in mind. Any of the ACE inhibitors will be okay.
Got it. Okay. Good to know.
When we look at a critical limb ischemia, as I said, of course, inflow is important, SFA, iliac is important, but now we start talking about below the knee. And for below the knee, the reason many patients don't get treated because it's a challenging anatomy, it's a challenging vessels to treat. And we have areas of the proximal part, there's some good data for it. The mid to distal part of the below the knee arteries is extremely challenging. There was a lot of randomized trials that failed. And the reason behind it, when we look at below the knee, it has more occlusions than stenosis in comparison to SFA, and long diffuse disease, more tortuous artery, more calcification, and there's a higher rate of failing to cross below the knee vessels. And of course, when you cross, we used to have limited technology. Now we have more and more technology advancement that I'm going to try to cover today in this talk. And if you look at calcification, not only increase the risk of complication when we have calcium. So this is just an example of a disaster when, an iliac artery rupture, and it's really humbling experience. I don't recommend anybody to have that experience, but it is something that can happen because calcium is not forgiving. But also, if the more calcium you have, from 1/4, 2/4, 3/4, or 360 calcification, less absorption of draconian balloon, and of course, significantly lower patency rate at 12 months. I mentioned this briefly. You look at CLI, especially Rutherford 5 and 6, when you have a wound or gangrene. It depends where that lesion is. You have to fix the artery that supply that vessel with. So, you can have, for example, a toe ulcer, and the only thing you open is the PT. You may have to open a PT with the arch or open the AT. So it's very important to, the angiosome is extremely important, and windosome is extremely important as well. So lesion assessment, it was very exciting to see that IVUS in the coronary became a class 1 indication. The European Society of Cardiology guidelines and the peripheral arterial disease were way behind. There's really low rate of utilization. Nowadays, with all the studies and research trials that we're part of, we're using IVUS more, and we're learning a lot. We're learning that the vessels are bigger than we expected. We're learning that calcium is more common than we expected, especially below the knee. And I think it's important to use IVUS more and more. We have some data on IVUS. There was a recent paper from Japan, IVUS DCB versus DCB alone, and there's a significant more patency rate at 1 year. We're getting more and more data on IVUS, and I think this is something might become at least class 2A in the peripheral very soon. If you look at possible treatment option, the old traditional way, which the most common way, is just balloon angioplasty. The problem is it can cause perforation, suboptimal outcome. Drug-eluting stent, there is data for it. I'm going to show you a slide of a paper, but that's mainly for the proximal part of below the knee vessels. These CP studies all has failed. There are new drug-coated balloon that's coming, the sirolimus or the limus drug-coating balloon that's very promising, that are accepted or approved in Europe. It's coming to the US. There's active trials right now. Of course, atherectomy, I'll show you some data about it as well. This is the study for the multiple studies for drug-eluting stent data for below the knee. Actually, pretty positive data to drug-eluting stent using coronary off-label use. Again, you have to size it correctly. You have to size it based on IVUS. But when we look at drug-coating balloon and all the studies that's been done, and at the bottom, I put a live PT case study, but I'll leave that alone because that requires its own slide, because it deserves its own slide. Unfortunately, most of the DCB trials has been disappointing, and that's why in the US, drug-coating balloon are not approved for below the knee. Hopefully that will change with the limus drug-coating balloon, but that at least a year or two away. When you look at atherectomy, There are different types of atherectomy. You have directional atherectomy. I'm not going to talk about devices per se, but as a genre, they have directional atherectomy, ablation atherectomy, rotational atherectomy, or orbital atherectomy. What's atherectomy for the non-interventionist? It's a device where we try to debulk this plaque, maybe soften the calcium a little bit, maybe get some of that atheroma out of the body and get a better lumen. And depends on the device and the way it works, but there's certain indication for each one of those. Actually, most of this has been studied below the knee. So this is just an example of the laser-assisted angioplasty of critical limb ischemia and a 6 months outcome. Pretty favorable outcome in those patients. Limb salvage 92% at 6 months. You will see a theme here for below the knee. What we look at below the knee, because in Europe, below the knee has been treated for claudication more commonly than the US. In the US, still the thought is below the knee only for critical limb ischemia. So most of the below the knee intervention and the primary outcome is limb salvage or mortality. It's very hard outcome, not just pain relief and walking distance. What atherectomy downside? Where there's a desymbolization, dissection. It's actually the biggest hurdle is the learning curve. A lot of physicians would not do atherectomy just because they have not trained to do atherectomy in their fellowship. That's why, as you mentioned, I'm the Endovascular Fellowship Program Director. I'm a believer that physicians should have some time to learn those technologies, not just to learn them on the spot. I mean, you can learn a lot of things while you're already at work, working, but I think it's important to dedicate some time for learning either through courses or a dedicated year. What other specialty balloon or treatment we have? We have the serration technology, and it's a very fascinating technology. A lot of people think it's like an angiosculpt or it's a scoring balloon. It is completely different. The way it works, you see this pinpoint in that balloon. When you compare it to an angiosculpt, for example, angiosculpt at that point, the power is 24 times the power of the regular balloon, where in the serration technology is thousands time. And based on the trial that was published in Leipzig last year, it actually showed a significant improvement in patency rate, limb salvage, but also much less recoil. It's very fascinating technology that's not a lot of hospital has it. I think the company has to do a better job bringing that technology to the front. The other one is really cool. It's called reflow. It's called retrievable stent therapy, which basically what it is a scaffold, a stent scaffold that you go in, you deploy it, you sit there, let the scaffold kind of prevent dissection, expand the vessel, not worry about dissection or perforation, and then you retrieve it. So you leave the body without a stent. It's really fascinating technology. I think this is something also becoming more and more popular. They just finished their initial trial, and now they're starting the new trial with this which is the medicated retrievable stent therapy. What about live BTK? For people who works in below the knee, has been frustrating for a long, long time because every trial we have has been disappointing. Live BTK was a breath of fresh air. Really exciting result. We looked at freedom from amputation, above ankle occlusion, clinical revascularization. The primary outcome 74% in the everolimus drug reabsorbable scaffold versus 44% for the gold standard angioplasty group. Significant improvement. The 2 years outcome was published last year at Viva and showed a consistency of the result at 2 years. And when they did a sub-analysis to look at, for example, CTO, maybe a longer lesion. Remember, this is a randomized trial. There's some restriction about it, about the length of the lesion. But even with the more complex cases, the bioabsorbable scaffold has done actually much better than the PTA. I'm going to pause here, see if there's any question before I keep going.
There's a lot of question came about medical therapy. Like after you intervene, I'm not sure if you have after. How do you manage this patient and maintenance of therapy?
Yeah, so if you have an intervention, dual antiplatelet is extremely important. Aspirin for life, Plavix I usually recommend a year, 3 months to 12 months. If patients has extensive disease, you can swap the aspirin with Xarelto 2.5 milligram twice daily in addition to the Plavix, and then at the end, just keep them at a maintenance dose of a 2.5 twice a day. Statin is very similar to cardiology and cardiovascular disease and cerebrovascular disease. It's a high-dose statin, the highest tolerable statin, and if we can get the LDL below 70 or now 55, that would be great. If a patient has high blood pressure, ACE inhibitor has shown more positive result. Celestazole, it has kind of conflicting data. The only issue with Celestazole, if you put patient on Celestazole and you try to put them on Xarelto, the pharmacist will call you and will not be comfortable prescribing both. So if I have to choose between Celestazole versus a rivaroxaban, I'll use rivaroxaban in that situation.
While you are talking about Celestazole, what are the contraindications for Celestazole? Just for
the main thing is heart failure. I think that's the biggest one that you have to pay attention to. Patient who has advanced heart failure, I would say I would avoid Celestazole.
And if you, as you said, how about antiplatelet therapy, aspirin Plavix or aspirin clopidogrel? Would you add also rivaroxaban?
So the data showed when you look at the Voyage trial and the Compass trial, they actually, if you do triple therapy, you get better overall result in terms of positive outcome, but then you trade that with bleeding, a significant increase of bleeding. That's why I would recommend dropping the aspirin when you start rivaroxaban 2.5. And remember, this is a 2.5 twice a day. That is not 20 milligram. It's not 15 milligram. So it's not the DVT AFib therapeutic dose.
Have you ever held 2.5 before a procedure, or you, let's say somebody comes and he took his morning dose, would you continue with the procedure, or you have to hold it?
We hold it. We created that protocol, and I think not based on really data, just because we don't want to create a confusion. We have a lot of patients on Xarelto 20 or 15, and it's really hard to kind of specify this, because when the patient, when the schedulers and the hospital and everybody who's working on the patient see rivaroxaban, they may not know the difference between 2.5, 15, or 20. So for us, what we do, we hold it for 24 hours if the patient normal creatinine, and 48 hours if the patient has abnormal creatinine.
There is a lot of, I mean, and this is also including me, sometimes vascular surgery, for example, take the patient to an angiogram, and we don't know when they determine patient need to go for endovascular therapy and when is for bypass surgery. Do you know, like, roughly when is patients be favorable for bypass versus endovascular?
Yeah. So, oh man, this is a 1 hour conversation. Maybe we can do another webinar for this. There was two studies that
there is a massive Sameh, because there is a hospitalist, there is a nurse practitioner in the practice, and they don't know, okay, why sometimes endovascular and balloon angioplasty, you guys took it in cardiology, and vascular do bypass. So just in a nutshell.
Yeah, a nutshell is really will be dependent on the person that the patient being sent to. I mean, with all honesty, for us, the way we look at it, you have to achieve. So they have, first of all, you look at the patient risk. So FEMBOP bypass, it is not a low risk surgery. It's definitely a moderate, sometimes high risk surgery on most of our patients. And again, you need to look at the patient from the complexity. So if I have, for example, a patient who is 6-year-old who has severely calcified occluded SFA, that I know that I'm going to be in dissection and then true luminal dissection, we know that patency rate for those patients endovascularly is not good. Same time, if you have a patient who've had heart bypass surgery and they don't have any superficial vein for bypass, so the prosthetic bypass that's used surgically is actually has not a good patency rate, has a higher risk of infection. If you have so the endovascular therapy has improved significantly over the last 5 to 10 years, to the point that for interventional radiologists, interventional cardiologists, and big part of the vascular surgery community, there's a trend now towards more endovascular therapy. You need to have a good proximal anastomosis site and a good distal anastomosis site. So for example, if you have a diffuse disease all the way to mid AT and you have to bypass from the femoral artery to the ankle, the patency rate is less than 20%. So it's better to do endovascular therapy on those patients. So there's a lot of factors that play a role, but definitely who's taking care of the patient absolutely play a role. Because you have, even with interventional cardiology, interventional radiology, and vascular surgeon, there's a lot of endovascular therapists, operators, but not everybody does CLI. They get to below the knee and they stop and say, well, instead of, which I recommend, if you do not do CLI, which is okay, to partner with someone who does CLI work, because I'll show you some of the stuff that the technology that's happening now, and it's going to really blow a lot of people's mind, because the technology for endovascular has really advanced significantly recently. And I'll show actually a case of what's called percutaneous bypass that we start doing. And deep vein arterialization, which also it's really changing the way, instead of amputating people's leg, you can do something to help.
Yeah. So far, from the epidemiological standpoint, what we hear so far is a pandemic problem. If somebody has CAD, they have PAD, you have to screen for it. If somebody had symptoms of claudication or critical limb ischemia with an ulcer, they have to have a referral to endovascular therapists, or sorry, interventionist,
Vascular
or
specialist.
CTA, or some more comfort vascular bed to avoid amputation. And for sure, amputation associated with higher risk of mortality.
That's a very nice summary. There is, first of all, is that we need to have a way that our patient, when they come to see us, the same way we give a screening question about, do you have chest pain, do you have shortness of breath, is, do you have leg discomfort? Do you have a wound? Do you have an infection? Because the patient will not share that. Patient will not share they have a toe infection after their nail were taken out, or they cut their nail and have a small wound. So I think, and also this CLI is a true multi-specialty disease. When we talk about having many people talking and working with the patient and taking care of the patient, you can't ignore the role of the podiatrist. You cannot ignore the role of the wound specialist, the endocrinologist. Everybody play a role that is important. And I think the primary care physician behind the scene is the maestro, kind of make sure people are getting done the right way, and finding the right partner.
Yeah.
You may have to send your patient 20 miles away to see the right doctor. Taking shortcut equal more amputation, unfortunately. So I'm going to proceed with some of the technology, because I think this is something maybe the audience would really want to hear. So intravascular therapy, for all the cardiologists, vascular surgeons, interventional cardiologists, you've heard this. This is how it works. This is how I want to show you the video. It is basically an emitter that creates energy, that create this micro bubble that penetrate and go and break the calcium in a safe way. It's super easy to use. There's no learning curve to it, comparing to atherectomy. And if you look at the data for it, it's really safe. Like, you look at this data here with 0.000 complication, that has really blew people's mind. That's why people start using IVL a lot. And if you look at, is there below the knee data? There is. The initial trial was only 20 patients, 30 days, great outcome, called DISRUPT-BTK primary endpoint, DISRUPT-BTK study. That was great, 20 patients, right? Selected patients. So the company, physicians said, well, I'll use it, but I need better data. And what they did, they designed what the DISRUPT-BTK2 trial. We were honored and privileged to be part of this trial. And this study was, the 30 days outcome was published at Viva last year, and the 1-year outcome should be published this year. And it looks at single arm study of below the knee intervention in heavily calcified vessel. At least moderate calcification, relative classification 3 to 5, and very long lesions. We look at safety endpoint, that we'll call the adverse limb event, and of course, post-operative death at 30 days. Remember, as I mentioned, CLI patient, we don't look at walking distance. This has become a secondary endpoint. The primary endpoint is death, losing legs, more severe endpoint, or more hardcore endpoint, hard endpoint. 250 patient enrolled in the study, 305 lesions, received IVL. I'll show you the final result. So minimal lumen, start with 0.7, end up with 2.4. And to show you, those vessels below the knee are not small vessel. We're talking about between 2.5 to almost 4 millimeter vessel improvement of stenosis from average 78% to 26%. When you look at angiographic complication, very, very, very low, less than 1%. This is just an example of this data. All-cause mortality was 0. Above the knee amputation was 0.8, and major intervention is 0. So that's 30 days. Hopefully we can find, we will have the 1-year outcome data this year. And I think this is be very exciting to show, because it is something that has been very helpful, because it's easy to use, and patients and patients deserve the best outcome. And IVL has been a really a game changer in the coronary and in the vascular as well. When we talk about the quality of life, there's a significant improvement in quality of life from walking, from social concern, from pain. The patient who cannot walk is a patient who's not socially active. And if the patient is not socially active, they are unfortunately increase the burden on healthcare system and in the society as a whole. So it's extremely important to look at that. So you asked me if there's something crazy came out recently in endovascular. This is the next couple of slides. I'm really excited to show it, because not a lot of people who know, but not a lot of people know about it, unless you are in this kind of, in a way, select operators who does a lot of CLI work. This is an idea that came out, and I wish I came up with it, but I did not. So I'm very jealous from all the pioneers who came up with this idea. And what they decided to do is, if below the knee we don't have vessels, instead of amputation, can we connect the artery to the vein and get an extra flow to the vein? And what happened in this situation? And what they find out is actually the vein turned to an artery after some time. So increase the flow. And I'll show you an example of this case. And this is we'll call it a DVA. So if you hear someone saying DVA, that's the deep vein arterialization. And it was a crazy idea when it came out. And the first study that studied it, Dr. Mustafa was the first author, and Dr. Peter Schneider was the senior author. This is cardiology. This is vascular surgery. This is really pioneer in this field. Came out significantly impressive. Those are the patients who are basically, they are going to get an amputation. If you look at the primary endpoint, survival, the freedom from amputation and amputation-free survival, significantly better in this patient population than balloon angioplasty or nothing. So those patients usually have an amputation rate of, let's say, 90% or so. So we're talking about freedom from amputation or 77%. It's a difficult technology to learn. It really needs dedication, needs someone to have a right team for it. But the moment you learn it, you will treat a lot of patients that otherwise will receive an amputation. And Dr. Shishapur came in, he was one of the pioneers early on, and he ran the PROMISE 2 investigation trial, and that also came back very positive. And just show you an example here, because I don't want to bore people with just data. So this is a picture. Remember, you guys remember the picture we showed you before with the normal arteries. Here you have no arteries. Those all collaterals. And this patient has a wound here. You're getting no flow. This is not enough flow to heal the wound. So what you do is you connect to the vein. This is the vein. You get all the way down here. You put a cover stent, and you disrupt the vein valves. And what happened is, it's basically you create a fistula. And if you notice, this is a month or two afterward, you see this absolutely beautiful, beautiful filling all the way to the toes and wound healing.
So basically, what it is, just to explain to the audience, do you have any different picture or cartoon? Because what I'm understanding is artery completely diseased or blocked. You jump to the vein, hop on the different lane, and then reconnect back again to the artery?
No, you do not connect to the artery. So as a concept, if you remember, the way that AV fistula work is you connect artery to the vein without coming back. This is exactly the same way. So initially when that happened, I don't know if it happened by mistake and people just connecting it, because we connect artery with vein all the time in the legs because they're very close to each other. If you remember anatomy, medical school, right? I don't know if a lot of people remember leg anatomy in medical school, but you go below the knee, every artery has two veins next to each other, and they're very close. And what they do is they connect the artery to the vein and connect them with a stent, a cover stent. This way, when the blood comes forward, it's just going to go all the way to the vein and just come back and flow. And what happened, because the high pressure that's get created from that flow, those distal veins, they basically turn to arteries. So they start supplying the wound with all the oxygenation you need. Because the way to heal the wound is you need to get them to deliver some oxygen here, one way or the other. And you'll see with the CLI, you want to prevent death, you want to prevent amputation. And sometimes if you go from a BKA to metatarsal amputation, there's a significant mortality benefit to it. If you go from a metatarsal amputation to a toe amputation, there's significant mortality and significant social improvements. So the patient will be able to mobile, they don't need a prosthesis. So this is where the technology is. It's really fascinating technology that's initially people used to do it based like a off the shelf. You know, there's something called a pioneer recrossing device where you can see where the vein is. You poke a needle, you get there, you do a what called a Viabond cover stent, just all off-label use. And now there's a whole company that's part of Inari Medical that is dedicated to this. So it is a growing field. I think it's a great technology to help minimizing amputation. Does that make sense?
Yeah, absolutely. So you basically the vein, and you mentioned something about disrupting the valves and the vein because you want to make sure the flow is go antegrade and then to the artery.
Correct. Because the vein is going to have tendency to pull the blood back, and if you have that, you're going to create a resistance to the flow, and the stent will close.
Yeah, it's impressive.
And it's important for podiatrists, primary care physicians, wound physicians, when they see a patient who just had a DVA, to be very patient, because this extreme hyperemia, the wound is going to look very angry, but that's a good thing. So when you debride the patient, you're going to have a lot of bleeding. That's a good thing. You have to be patient. You have to let it, mature, and not to jump just because it look ugly to jump for amputation. Unfortunately, because of lack of communication, because in the United States we don't have one healthcare system, one EMR. Patient go to a different hospital, they have no idea what the patient received, and they get an amputation. So I recommend if someone had a DVA or had a procedure, just call the physician who did it just for continuity of care.
You're right, yeah. But as you said, if a misunderstanding because a new concept. So if the patient goes out to a different institution, might end up with amputation, yeah. Correct.
So we talk about EVL. This is a new device from the IVL therapy. It's called E8. It's better crossing. I'm going to give you an example. We're going to run through a couple of examples in the next 12 minutes of different technology, different devices. This is basically a very sharp angle anterior tibial. It has lesion all the way through it. It has a lesion here. And this is basically an E8 it's an IVL device, and this is a solo therapy. See how bigger of a vessel that is. That's what IVL has taught us, is that below the knee vessels, and we learned that in the coronary as well.
Yeah.
Coronary arteries post-IVL look much bigger than pre-IVL.
And is it true about the IVL, the recoil of the artery is less compared to just balloon angioplasty?
I don't think there was any publication for that, but there's many case series and case report when people like for example, you fix the AT and you go to fix the PT, it takes you an hour. In the old days, if you do that with the balloon angioplasty and you take a picture, you definitely will see an acute recoil of the first vessel. We're not seeing that, and I think that's because the IVL not only disrupt the intima calcium but also the media. So create a more compliance in the vessel. So I usually see exactly what you said, less acute recoil.
Thank you.
This is another example of IVL. This is a patient who came to me for a second opinion after he was told there's nothing that can be done. They even said he does not have an option for bypass surgery because there's no distal vessel, and they only offered him amputation. This is actually 2 years ago, and this is what we end up with.
Wow.
Pure old-fashioned IVL, single catheter, actually one of the older devices, and two vessel runoff looks great. I think this patient, really, I'm happy that he did not receive an amputation. I think he could end up with a toe amputation instead of a BKA.
Yeah. One question, Sameh, also about sometimes the amputation is inevitable, like means it's going to happen. But what you are doing by salvaging, basically, you are delaying that amputation. Is that true also? Like, is it because of the anatomy? Is it the patient compliance?
Yeah, I mean, the patient compliance is a problem in a lot of centers. Like I think your center, our center, and a lot of big hospitals, it's a tertiary center where you get a lot of referrals from 5 hours away. You do all the work, you talk to the patient, but then you have to depend on the primary physician, either a primary care physician, a wound doctor, a cardiologist, vascular doctor, whoever sent you that patient, to be very, following this patient the way you would follow them. And as I said, this is cancer-like treatment. You can't, for example, send patient for cancer, you give them 5 doses of therapy and send them home and say, see me in 3 years. They will come with another cancer, or the cancer will return, or dead. Unfortunately, that's what it is. I think it's require better communication among operators and healthcare providers. Patient compliance, I think if you're true to your patient, and if you're direct with your patient, I think the patient understand, because most of these patients have been told it. So I had a patient recently, this is a true story, last week, referred to me 5 hours away, come in, right leg is amputated, the left leg has resting pain, and I was talking to him what we're gonna do, and he said, so when are you gonna amputate my left leg? I said, I don't amputate. I'm not a vascular surgeon, I'm not a wound doctor, I don't do amputation. But you're not here for amputation, we're here to prevent amputation. And when you talk to him, they amputated his right leg because he had pain with walking, not even resting pain. Unfortunately, that happens because either the patient doesn't get to the right physician who has someone who does CLI, or the
Yeah,
patient doesn't know better, right? I mean, unfortunately, we are
unfortunately.
the advocate for our patients. So, but I don't think patient will get an amputation. I don't think that's a true statement. Many of our patients end up no amputation. Yes, there's some patient you may minimize the amount of amputation. So you go from a BKA to metatarsal, from metatarsal to toe amputation. And as I said, it has better outcome. Make sense?
Very perfect sense. Yeah.
So I'll show a
Okay.
few other cases, just kind of keep it exciting. So for the CLI societies and people who does a lot of critical ischemia, we do a lot of pedal access. As I said, everything is allowed to get that artery open. So we poke people from wrist, from groin, from SFA directly, from ankle, from foot, from toes. There's no any area that we don't poke, as long as you can achieve patients. But what if you don't have a pedal access? So this is the case I did 2 weeks ago or 3 weeks ago. Nice lady, had a previous FEMPOP bypass. So this is an example of nothing works forever. Bypass, not in the heart, not in the leg, works for life. No stent work for life. So this is an example. So had started having resting pain, respiratory classification 4, ABI showed 0.4, and had showed the occluded SFA, and the bypass was also occluded. Another hospital tried accessing the pedal. They would not be able to cross, so referred for a second opinion. And if you look at the picture here, just for people who doesn't do this for a living, this is the groin area, this is the profunda, and this is the SFA. The SFA is completely occluded. Usually the bypass vein comes somewhere here, that's occluded as well. And you can see it reconstitute at the canal above the knee. This is below the knee. I just don't see any vessels. I think when they poked the AT, they disrupted that location. So at this point, you can try to stick the AT again. I can do a direct SFA stick right here, but just to keep things exciting, and for us as a cardiologist, we have the advantage of using wires in the coronary. Sometimes we use it in the peripheral and vice versa. So in this case, I just show you the profunda, a lot of collaterals. The most important artery of the leg is the profunda. And what we did here in this situation is we did a retrograde transprofunda crossing of the SFA, similar to what we do in coronary CTO through collaterals. And you'll see here that's cyan black. It's a coronary wire. It's not a peripheral wire. And you put your turnpike LP. This is for the cardiologist. They know what I'm talking about. This is something we use all the time. And boom, you go through it backward. There we go. Then you connect the dots and you get your wire through from the top. Here's we did a laser atherectomy, the device called ARIA from Angio-Dynamic, followed by the serration technology. Remember I told you that serration technology with the serration balloon that has this kind of blade coming out. This is a DCB and this is the final result, no stent.
Wow.
So as I said, patient has a resting pain, patient has a wound, things needs to be taken care of. I think maybe I have two more. I have two more cases.
Please go ahead. Yeah.
Will be done. I just want to show everything possible now in this technology. Just, this is a case of a patient, 75-year-old, history of PAD, carotid disease, had a carotid endarterectomy, heart failure, obesity, hyperlipidemia. So obesity increased the risk of infection for surgical bypass, heart failure increased the risk of mortality and complication. So she came with worsening claudication and developed some resting pain. And if you look at her, this is the ultrasound with an ABI, 0.5 on the right, 0.7 on the left. So I'm going to show you what's called detour. Detour, this is the picture here on the right side. What it shows is a lot of wiggly things. I'm going to try to explain what that is. They show you the artery in red and the vein in purple. And what you do, this is the percutaneous bypass, what's called detour. You go from the common femoral to the deep vein, all the way down, recross back to the popliteal, and you do the specialty cover stent, very flexible, and basically you get a percutaneous bypass, similar to the surgical bypass. The Detour study, Detour 2 study is an IDE study, had a final 3 years outcome and showed a 3 years patency rate of, primary patency rate of 58%. 1 year was 81%. Freedom from CDTLR is 66%. And if you look at bypass patency, which is 84% based on ultrasound. Freedom, everybody concerned, you're going through the deep vein in this situation. Are we increasing the risk of DVT? There are some criteria for the vein. You need more than 10 millimeters. The 10 millimeter should be your femoral vein. And if you follow that criteria, you have only 4% risk of DVT, symptomatic DVT. Most of those patients, I put them on blood thinners, like anticoagulation for a month, and that usually help a lot. And again, freedom from major amputation, it's a 98.5%. Pretty impressive data for those sick patients. So this is an example of what I'm talking about. This is my patient, CT scan, very calcified vessels, iliac there. I'm going to show you how it's get occluded, the common femoral, and then you get the profunda, and the SFA is completely occluded right there. So this is venous mapping, show a large vein just for the sake of time. This again, you guys see in the other picture, this is the left side, this is the profunda. SFA is completely occluded, there's nothing there. And then go back and get a collaterals back here. Fourth patient has prosthetic knee, and you have 2 vessel runoff. And we get an ultrasound guided vein access, and we put a sheet there. We do a venogram, make sure there's no DVT, large vein. That's just a connection. And we cross here to the occluded femoral artery, this wire in the vein, this wire in the artery. We balloon it. And now, here's the fun part. Here, what we have is we have the device that is called endocross. We have a snare in the vein, and this is from the artery. And what we do is we poke with a very, very sharp needle from the artery to the vein. We push the wire, we snare the wire. You can see here that we're going to snare that wire, and we pull it all the way down, And this is just technical things. We created a proximal anastomosis. You see it's very tight. I'm connecting artery with vein intentionally. And then I come back and I reconnect the vein back to the artery at the popliteal. You can see there, this is the vein, and boom, we're connected back to the artery. Balloon it, stented.
How do you know you're going to the vein? Because this is a 3D. How do you know you're going to the vein? Is it like 3 o'clock, 9 o'clock, 12?
Yeah, I skipped this. So there are two spots, one in the proximal and one in the distal, where the vein and the artery they cross, and it know where it is. And this is where how you so you want to do anterior. This is how you direct the needle in the proximal, and this is how we do it in the distal anastomosis. And most of the time, you are in the right location. Every once in a while, patient has different anatomy, and the way you do it is basically you rotate the arm, so the vein, you wire from the vein and you wire from the artery kind of overlap, and then you try to connect. I'll just show you a final result just for the sake of time. You put some cover stent there, and this is your final result. It looks like I think look nicer than a surgical bypass, if I can say so, though I'm biased. So this is beautiful result all the way there, two vessel runoff. This patient 8 months later or so. So in this patient, what I usually do, I put him on Xarelto. She did not fail her Xarelto. She had a lot of swelling. Venous ultrasound came back negative. I put her on 2.5 of Xarelto, and her swelling went away. Patient come back 8 months or so. This to show you another part of the technology that I'm a big fan of is the transradial access for percutaneous intervention. This patient just had the distal anastomosis, has some disease in it. So instead of providing our patient with a groin access and risk and everything else, we went radial, went in, did a drug coating balloon, excellent result. The whole procedure is 20 minutes, the patient home in 2 hours. If you let me 2 more minutes, I want to finish this one. Please. Because this is really my passion. I'm a big fan of the radial to peripheral technology. I think this is the way to go in the future. Where we are in the radial to peripheral is where we were in the radial to coronary 15 years ago. In our hospital, we're publishing the first, big study, hopefully very soon in TCT. And this is just an example of those cases. 80-year-old retired surgeon who came to see me for technically a third opinion, had a 4 intervention in the past, a clinical presentation of Rutherford classification for resting pain, and the first ever intervention was done based on a CTA that showed an occluded popliteal. This patient did not receive an angiogram. He received a distal fem to perineal bypass, which we know patency rate is not great. That within 6 months, of course, within a couple of months, it's thrombosed, had a surgical thrombectomy ×2, and eventually a percutaneous thrombectomy with a stent going from the distal graft to the perineal artery. Patency rate for those are really low. Come to see me, and we basically, what we see here, you can see that where the graft is, occluded popliteal. He actually had a proximal SFA stenosis, which I think why the graft also failed, but basically terrible vessel here. You can see reconstitute somewhere here. We end up fixing it, but this is not the cool part about it. It just, you have to go through the old stent, balloon it, DCB it, all the fancy stuff that you have to do. And you get a very nice single vessel runoff all the way to the foot, basically dominant perineal. Patient does very well. Here's the problem. Like all of us as physicians, we are terrible patients. So he disappeared for 2 years. This is, as I said, critical ischemia is not a every 2 years come see me when you can. So he come in and he has a pain in his foot. And actually, when I examine him, he has the wound that he didn't recognize. So he said, well, need to get you in. TBI was a significant drop, ultrasound showed occlusion. So when you talk to him, he had multiple groin access done for all of his procedures, had multiple groin complications, hematomas, pseudoaneurysm, all that other stuff. So he said, can I do this without sticking the groin? We said, well, we know what the anatomy is, definitely. So what we did, we went radial access, so radial to peripheral, what called R2P, and we went with a long sheet called a Tromoslender 149 centimeter sheet. We landed in a distal SFA. We took pictures. You can see basically all the stuff are closed off, and we're back to the first, picture with that terrible flow. We crossed with a micro catheter. It's called Sublime 200 with a wire escalation. We use a 220 centimeter laser that's available for radial access. If you notice, with this study, with this case, we used 5 different products from 5 different companies. To me, that's exciting because that means companies, medical device companies, are recognizing this is something that they need to invest in. And I think this is why we're able to do this transradially. Drug coating balloon from Medtronic, we covered. I know there's no data for below the knee. There's data in Europe. So I used that data for this case. But he had a stent that I needed DCB. And we finished up with this result.
Wow, beautiful.
Patient home in an hour or two.
That's one of the
Most
questions that came up also. Are these procedure outpatient, same day procedure, or what?
same-day procedures. So most of the radial patients, we send them home unless the patient requests to stay. That's the beauty of a radial intervention, transradial intervention. And to look at it, as I said, way early in literature. I think our hospital has published most of the literature for below the knee. We're proud of that. We're partnering with other hospitals as well and big centers to publish more and more. But if you look at the data, there's really two big papers looking at large size patient population to look at radial to peripheral. The one was published as JSCI 2023, Dr. Brown, a prospective multi-center registry, and there was 19% of the patient had below the knee disease. So it means, or intervention. So it's not just for the SFA, it's not just for the iliac, even for below the knee. Now with the other technology like a laser and longer balloon, we can do it in our hospital. And this is our first 100 patient that we published at AJC in 2024. 22.2% of our patients are below the knee. It's just something to show that it's not something that random. There is data to support it. And hopefully in the future, we'll see more and more of that data. CLI is a very exciting field, but I would say it is not a solo operator field. It is really a field where those patients require the help of everybody. Endocrinologist, if your patient diabetes is not controlled, you can spend $50,000 doing a procedure that leg will close the microvascular disease. If the patient's primary care physician not talking to them about smoking cessation, the one doctor not to bring in and being patient and treating those patients. So I hope that helps summarizing the technology. I don't think I covered everything. There is 5 ongoing trials right now for below the knee. So hopefully the next time we talk, we can update the audience for those 5 studies. Thank you for having me today.
Yeah, absolutely, Sameh. Thank you. And when a question came, how long was the plus case we just did finished, time-wise?
An hour and 40 minutes.
And another question is there always after DVA procedure, have you had to bring the patient back for coiling?
I have not. Coiling of what? I don't think you need to coil. I think that you know, if you have a perforation or you have a steel, sometimes you may have to, but most of the time, those patients, what we do, and that's where the beauty of having the ability to do transradial is I bring them back as transradial for after a month or two, just to make sure the vein has matured, the fistula has matured. And then if I need to do a touch-up, which sometimes just balloon angioplasty, I can do it from the radial. It's extremely important. One big part of this practice that we missed today and we didn't talk about, and I think it's extremely important, is sonographers. Pedal acceleration time, this is something that's becoming more and more popular. Most of the sonographers know how to do it because we're not spending time to teach them how to do it or send them to courses. But if you don't have a great sonographer, you're not going to have a good outcome because we really we depend on their beautiful skills to give us the data that we can move on with.
That's great. Again,
by the way, we reviewed our data. We had for the 100 patients, we had same or maybe less radiation time for radial, and we have less radiation exposure for radial comparing to like peripheral, the femoral. I cannot say it's a propensity match, but wait till TCT. We have something that you guys will be very exciting to present, and that's something hopefully will change the whole kind of radial to peripheral field.
Thank you so much again, Sameh, for your time and for amazing experience. Number one, with starting from the basics and diagnosis, and also to what are available on the market now, options for patients, especially desperate who are claudic or clinical nerve ischemia. And thanks for the audience. We have a plus 30 plus audience throughout the talk. That's like a credit for your very engaging talk and interesting cases that you shared. Thank you for the audience. Thanks for the team at FACET to arrange this webinar. And stay tuned with us. We come to you every third Thursday of the month at 5 Central, 6 Eastern Time with heart-rending again with topic related to endovascular, structural, and interventional cardiology and invasive cardiology imaging. Thank you, Dr. Sayfo, for your time, and have a good night, everyone.